The Meaning of Health podcast acknowledges the traditional custodians of the land where the podcast is produced, Whadjuk Noongar people. We pay our respects to elders past, present and all Aboriginal and Torres Strait Islander people listening. So hi everyone, welcome back to the Meaning of Health podcast. I'm Ingrid Stacey, your host for today's episodes. Today we're really lucky to have our podcast creator, Dr Craig Cumming, joining us. And we're also really lucky to have our student guest presenter with us, MPH student and president of the Population Health Postgraduate Society, Mr Rami Barake. So today's episode is a little unique. I'm going to claim it as part of the cardiovascular health series, but it really could start its own new series. Today we're going to be talking about public health dentistry, and we're really lucky to be joined today by Dr Junaid, who's a qualified dentist, a researcher and now a lecturer in the School of Medicine and Dentistry. Junaid's going to talk to us about his career and also shine a light upon the topic of dental public health. So, Junaid, thank you so much for joining us. Would you like to give our listeners a bit of a background about yourself, your education, career, and the work you're doing right now?
Yeah, thank you so very much for having me in this podcast. And this is my first podcast as well, so apologies if I do fumble a bit here and there. So how do I introduce myself? I've had now, of course, a long career. So we start very early. So I graduated from India. I finished my bachelor's degree from India in dentistry, going through those competitive examinations there, and then finished my master's degree in public health dentistry in India as well. And then thought, okay, let me try my luck with the UK. So I completed a few Royal College exams in the UK and managed to pass them. Completed a diploma in dental public health from the Royal College of Surgeons of England. So that gave me a world understanding about, I came outside of a developing kind of a public health country into a more developed world and how the system works in that area and that part of the world. And then I thought I belong in the UK. So essentially I was planning to give those registration exams and register as a dentist in the UK, so that because I was introduced to the chair of dental public health in England, so I was pretty keen on that. He was Professor Richard Ward, who is from the University College of London. And then it happened so that I coincidentally emailed Prof. Linda Slack-Smith, I don't know, but just emailed her during my work when I was working in India. And that conversation, one led to the other. I was also working a lot with kids with clefts, so we thought I should do a PhD. So then one thing led to the other. I got a fully funded scholarship and I landed here in Australia, and then pursued a PhD, got a few grants along the way as a PhD student, and thought, oh, this is what I have to do. Learned a lot about epidemiology, linked data. That kind of strengthened my portfolio. And it happened so that there was a position here that was here within the dental school for dental public health. And it felt that I sort of gained all the experience outside and then I'm coming back home. So it was good that I was lucky that I was selected through an interview. And then here I am. So my current role is that of a senior lecturer in dental public health at the University of Western Australia Dental School and the Oral Health Centre of Western Australia. For those who don't know, this is an 80-year-old institution, basically. We just celebrated our 80th anniversary last night. So I was there attending that function. We had the first cohort actually speak. He was 97 years and he's still alive and the oldest registered dentist on the other side. So, so it has a lot of history, a lot of tradition. Most of the dentists you have in WA are actually graduates from the UWA Dental School, and that responsibility of teaching them dental public health. And because considering I'm the only dental public health person within the school, so I sort of lead the discipline here and a lot of responsibilities. Teach the Doctor of Dental Medicine students, at the same time research population oral health, do a day of clinics at the oral health center, so practice general dentistry, and at the same time run the public health activities for the oral health center. So it's a very responsible position, and so that's why I'm finding it really hard nowadays to reaching that work-life balance, which I could but before this position. But I love doing this because this is what I thought I wanted, and I got it. So yeah, so that's my role basically. I've sort of moved across countries, and I've finally found my home.
Yeah, that's a great intro. Thanks, Junaid. I'm just wondering if there's any aspect about all those elements of your job that you particularly like, because you do quite a few things.
I love the direct contact I have with the patients through my general dental practice, and how I can improve their health at an immediate level, and at the same time how I can use that and apply that at a population level. And it's amazing if you do clinical practice and then you also do population health. It's amazing how we look at things differently. And then you're basically speaking to your consumers, really, from a research perspective, every day, day in, day out, and understanding what they want. And you keep your knowledge contemporary. So what I've realized in population health is we mostly do research and evidence, which could produce evidence which could be contrary or probably not aligning with what our consumers want. And by doing that clinical practice and by engaging with my patients, I realize, oh, this is what they want, and what are we doing? Are we really addressing this issue? And especially with Aqua, our patients are not very well off. So they essentially hold concession cards, like what we call a healthcare card, or they're pensioners. So reasonably high needs. They're not like low needs. And when they come to you, they come with numerous problems and they want you to attend to them. Long wait lists. So we probably discuss that as we go along. But yeah, so I think that's one of the parts of my job I love. That ability to connect, and that merging and that interlacing between how clinical and in clinical practice informs public health practice, and how public health practice informs clinical practice helps me understand the determinants better, and what we call person-centered care at a clinical level.
Mm. Yeah, so there's a lot of problem solving by the sounds of it.
Yeah.
Well, I think we're incredibly lucky to have you here in Perth, Junaid. I think your background, in various settings and at a global level is really beneficial to Perth. So we're really happy you chose this and chose UWA as your place to be. Can I please ask you, I'm not a dentist, obviously a user of dental services. Why is dental health so important to us? I mean, it's just teeth, isn't it? Or is it more?
Well, I think we all know now that it's more. It's a lot more. Yeah. So again, I think that's one of the reasons why we have had inadequate funding, because we've looked at dental health, or what we used to call dental health before, and now it's oral health. We looked at it in silos. So basically, we thought what happens in the mouth stays in the mouth, and that again, it's that blame. We have to take some of the blame as dentists as well, because our training has been very biomedical, and we don't communicate that well with our patients. So essentially, to answer your question, oral health is extremely important because it is integral to general health. So without teeth, you won't be able to eat, won't be able to chew. That affects your nutrition, the choice of food. And then ultimately, again, as I said, broadly your nutrition and how much you weigh and all the other outcomes. Apart from just eating, speech, the way you talk, your teeth are integral to that. The way you speak, again, the dental labial sounds that make you make your voice appears more refined and nuanced, and all that stuff, which your teeth are important for that. Imagine people without teeth have very muffled voices. Then obviously your smile, and with smile comes the confidence to meet people, to interact with people, and that affects your mental health, your social health, your ability to engage with people, and how your personality per se, how you engage, and then how you get a job, really. So essentially, it's so tied up. So the impacts of oral health is huge. And then if you have oral problems and diseases, that is, again, a lot. The impacts are huge as well, because it's number one, it's not very it's a harder structure of the body, the teeth. Again, for those who don't know the anatomy of the teeth, the enamel is the hardest structure of the body. And if you have a very reasonably healthy tooth, and you can recover those teeth ages after you've gone. So people actually extract teeth and from the soil and basically try to trace the DNA through that. And that's how hard the tooth is. But then it's easily destroyed by sugar and the foods and choices we eat and the food choices we have. So the dental problems are huge as well, and the ramifications and the negative impacts, obviously, because bad teeth would mean would obviously hurt all the other aspects of chewing, which we call mastication, speech. And again, to keep that answer pretty basic and short, oral health is integral to general health, wide-ranging impacts and affects your quality of life as well as your experience.
So it's really interesting that you've talked about all those factors that people don't really think about. But a lot of my research is done with people from vulnerable, marginalised populations who are often disadvantaged, and their health is one of the things that often suffers. I'm talking about people who move through prison, who experience homelessness, etc. And I think that without realising it, I think that's one of the first things we notice about someone is their teeth, and sometimes if they've got missing teeth or teeth that are clearly not healthy, and I think it does prejudice our view of people, like in the first instance, before we even speak to them. It's like, oh God, look at that person, they're missing teeth. There's obviously something going on there. We might make a link with substance use or, something else. And it's interesting to hear you talk about people's confidence. But really, I'd say oral health is probably at the pointy end of the social determinants of health, right?
Yeah, it's very intricately connected to the wider social determinants of health.
Yeah,
I do agree because, and I do agree with the point that how we are prejudiced in terms of looking at a person and looking at how the person's smile is. And so I think that's where we are fixated as humans as well, isn't it? So it's very unfortunate.
Do you have a lot of people, from the lower socioeconomic groups come through, your clinic, and and what's your approach to trying to help them in particular?
That's an interesting question. So we obviously have a lot of people who are from the disadvantaged populations who actually access our service. So it depends, again, personalized care is what we do. And again, we consider the person's wider determinants before actually planning treatment. Most of their teeth are almost at the final stages, as I would say. I mean, either it has to be extracted or removed. And then people don't really want to be pressured to be removing those teeth. So making those shared decision makings, just telling them what the treatment plan is, engaging with them, getting the consent and planning a path forward. So we don't really push, although we have a substantial treatment plan for them, we don't really push treatment on them because we understand that it might affect them by other ways. Because what we've realized is that our patients do feel that we pressure them a lot for treatment. And I think we basically, for such patients, we actually rely on shared decision making and then plan the treatment. I don't know if that answered your question.
Yeah, it did. So I'm wondering what sort of needs you try to assess, because you just mentioned there that it's not just about the teeth, but there's other factors as well. So typically, what sort of questions might you ask somebody?
So we do have a set template of questions. Again, to be honest, we have very limited time in our schedule to actually see patients as well, because it's a government clinic. We are expected, there's a long wait list, so we're expected to see people quickly. But as much as possible, we will review their medical history. At the same time, casually just speak with them, just have a conversation with them initially, just greet them and expect them to open up. So, which they do, which most of our patients do. And then we understand, these are their challenges. And that could be a lot. I mean, we've had people who have experienced domestic violence as well. And just the sight of the dental chair, the light that comes out of the dental chair may trigger them. And how you put that light away from their eyes That again is a thing. How you stand in front of them, how you standing and speaking with them, that again will just the power imbalance issue arises there. You sit at their level, speak with them, listen. I think that's the most important thing we do. We listen a lot. And we expect the patients to open up. We can't probe. It's very difficult for us to probe, because probing, again, sometimes we are reaching the territory of personal invasion, and how so asking the right questions that are broad and expect the patients to open up and then understand them, and then plan the treatment one step at a time and tell them, look, this is what you need, but we will go by what you say. So see, this is urgent. This needs to be removed. Would you agree with it? It's not painful today. Okay, some patients would say, oh, it's not painful today. Can I get it done later? I want a simpler treatment done today. Yes, surely. You can desensitize them. You can go for a scale and clean, and then schedule the appointment for say a tooth removal later. So we sort of balance it that's how we balance it based on their needs. But then it depends on what sort of appointment it is. So if it is an emergency appointment, we have to obviously treat the emergency which they've reported for. So that questions and allowing them the time to speak, unfortunately, is lesser in an emergency appointment in a public setting. But if it's a booked appointment, there is a potential, the chance that we can delve into those aspects of the patient and plan and do a decision making, because we have an 011 appointment, basically a consult before we actually start our treatment.
I think one of the things that's lesser known about oral health, and I've experienced this in the prison system, is that untreated, problems with teeth can lead actually to death in the worst cases, right? Like through infection, like sepsis.
Yes.
Yeah.
So we have a condition called Ludwig's angina. I don't know if I'm pronouncing it correctly. So that's the other thing, which is very interesting. You bring that, because I was looking at the reasons of potentially preventable hospitalizations, and I see that dental conditions is among the fourth or the third or the fourth condition. And current data, for acute conditions. But funnily so, the one that comes above it is cellulitis. And cellulitis, few of the contributing reasons of facial cellulitis are dental conditions as well. So how are we recording that is another question from a population health perspective. But dental diseases, most of them shouldn't kill you, but acute conditions can, as in if the infection spreads, or we have facial spaces around us, some puffy areas where infections and abscesses can kind of, those infections can spread and become cellulitis, basically. And then there is once they head into the Lincoln's pathway, as we call it, it's a direct pathway to your mediastinum, and then it's dangerous because it can cause multiple problems. So yes, I do agree. And then again, it depends on whether you're immunocompromised as well. So if you are a diabetic, you are at higher risk. But again, frankly, to be honest, I'm not scaring everyone. Dental diseases mostly don't kill you, so don't be scared. However, it's important that you attend to them because they may lead to problems in the future.
That's fascinating, Junaid. I think, I'm learning so much from you about all of this. I guess following on from Craig's question, my passion is cardiovascular epidemiology, and I'm really intrigued by that connection between oral health and the heart that you've touched on. And coming from rheumatic heart disease background, infective endocarditis is one of the outcomes. And, is that via the teeth this is happening, or can you talk a bit more about that, please?
Yeah. So first, just because you brought up infectious endocarditis, I'll discuss about that. And then again, the broader aspect of gum health and heart health, because that's somewhat connected. So with rheumatic heart disease and valvular heart disease in general, so now what happens is IE, as we call infectious endocarditis, is a complication because it's caused by bacteria that form colonies there on those valves, and those bacteria originate from your mouth. and they are called we call it the viridan streptococci, which is the alpha hemolytic streptococci. For microbiology nerds could probably look up. So those group of organisms, especially when there's bacteremia, if your teeth are terribly bad and you have bleeding gums, they can kind of enter into your bloodstream, and then they kind of make a new house and like a system on your valves, and then they cause problems. So yes, there is a direct connection there. However, most of the connections which you have had for poor gum health and oral health with cardiovascular health is still mostly as associations. It's not yet causal. So we should be very careful to connect causality to it, although my friends in the discipline of periodontology, which actually studies periodontal diseases, would disagree with me. But as an epidemiologist, I would still disagree with them because, again, oral diseases, as you know, gum diseases are caused by a host of microorganisms. They build a house on literally their homes. You know, we find it hard to build houses nowadays, but they find it really easy to build theirs on their teeth. And they just don't build by themselves. They have their mates to come along with them. And it's basically, it's a free for all on our teeth, really, if you don't maintain our teeth properly. So what happens is they sort of cause inflammation in your gums. And those inflammatory markers are the ones which actually work on our vessel walls, and they can cause atherosclerosis, a condition, and then subsequently leading to heart and cerebrovascular accidents. But that direct causal link is still not really there because there are multiple confounders. For instance, as much as smoking can affect heart health, smoking can also affect gum health. So how you disconnect that is important. So you should be so when people talk about it, yes, there is. You obviously, it's good to have a good mouth. You should have a good oral hygiene. That's mandatory. So I should promote this. But at the same time, I have to be very careful before using the word or connecting it causally, because that's important. And the other thing we need to know here is that in dental public health and in dentistry, the wider thing that's going around is the common risk factors, which we talk about. So every disease, oral disease, or generally oral disease is connected to other general health conditions because we share common risk factors, really. So as I just mentioned, smoking, gum disease, and heart health. You know, there's a lot of connection. It's not just smoking, obesity, and there's a lot of issues with sugar. So that connection is always there. And causal relationships, no. But with IE, yes, there is a bacteria which you harbor in your mouth, and there is a direct link.
That's so interesting. And I think so fixing your teeth is not going to improve your heart health and vice versa. It's more I'm
not going to that extent.
The common root cause of,
you need to fix your teeth. You need to fix your teeth irrespective. You need to irrespective. So I don't want to stretch and move it towards causal, but that still means you need to fix your teeth because you need to have good teeth anyway, because you want to stop any inflammation. Because now our periodontists are in the research now that's happening. They have a separate discipline within the periodontal discipline, which is called periodontal medicine, which is actually exploring aspects of this. So gum disease basically leads to inflammation around your gums. So your inflammatory markers are higher. So now the investigations are more around those inflammatory markers and connecting. So possibly in the future, we may get a direct causal link because they're connecting markers with all the tests we're doing. But as of today, the direct causal link is not there. It's one of those, as we put the Rothman's pie, it's one of those which contributes, but not directly.
Feeling the urgent need to floss now, Junaid. You've convinced me.
Yeah. I mean, one of the things that's coming through here is that obviously, like everything in health, prevention's a lot better than trying to cure things that have gone wrong. And I've been guilty of not going to the dentist in the past for many years at a time sometimes because I did a lot of traveling and it just became too hard. And then once you reach that sort of 2 or 3 year mark, you're like, I don't really want to go because what are they going to find?
I'm scared.
You shouldn't blame yourself. And I think that's something which we actually train our students as well, victim blaming. So we get into blaming because oral health, the other thing about oral health is our patients feel that they brought it on themselves. And one of that could be one of the reasons why they don't even visit the dentist, because they feel, my teeth are bad and probably I'm responsible for it. Or sometimes we had this discussion in Sydney traveled to Sydney for the consortium meeting, and then we were discussing about tooth sensitivity. And the thing which came up was like, our patients don't report tooth sensitivity because they feel that they are responsible for that sensitivity because they ate something and they got it. So I think that underreporting is very common. And I think as patients, we should, and as people, we should understand. And I mean, even if you want me, I should take the blame myself, because we all prioritize dental health and oral health at the end of our life problems. And that again is what we call, unless you reach that propensity related need, when you feel that you have to meet the dentist and your behavior changes, you don't really meet the dentist. So, and again, that's where the problems of access comes as well. So you've reached that need level, you want to get treated, there is demand, but then there's no service. So that's the other aspect which we can discuss later.
Yeah, so that sort of brings us, I think, to an interesting point around government funding and the fact that I don't think most dental services are actually on the Medicare schedule, right? So,
yeah, that's a very interesting question. Dentistry is underfunded. It's not that it's not funded at all by Medicare. So Medicare does fund one aspect of it, which is called the Child Dental Benefit Schedule. So that's currently being funded. That's for kids. So if I don't know, I may be wrong with the exact dollar amount, but I think it's about $1,158 for 2 calendar years. So which you cover for various treatments from 0 to 17 years of so for kids. So for the eligibility, I think you're supposed to. You're supposed to receive a family tax benefit part A, or you should receive some sort of payment. Now, that's the thing. So we all think that most families think we're not eligible for it. That's the thing. But the family tax benefit A is basically the money the government pays you to take care of your kids. And at times what happens is that income varies depending on the number of kids you have. So you may be thinking that you're earning about more than $100,000, and you think, I don't think I will be eligible for this. But then you have 4 dependents, so it might end up that you're eligible. So if you receive one of that benefit, you're basically eligible. And that's something which we're talking about, the underutilization of CDBS, basically, which we have seen from the dental sector. So with CDBS, it's technically like a scheme where you can visit the private dentist as well, and then your kids can get a variety of services, barring services of general anesthesia. So that's again another problem, because most of the kids with high needs will have really decayed teeth which would require general anesthesia, and CDBS doesn't cover that. So that's Medicare funds CDBS, and apart from CDBS, Medicare also funds a scheme which we are researching at the moment. That's Category 7, which is the cleft and craniofacial scheme. Now, this scheme provides dental services for kids who are born with a cleft condition or a host of other craniofacial conditions, and they provide them with subsidy to access dental services for that particular condition. And what we've realized with the initial research is that it's very, again, not very well utilized, because the remuneration and what the practitioner gets back from the scheme is very less. In fact, the same item code which you have for the CDBS, you get a lot more back as opposed to, say, a cleft scheme. So there is that's the 2 schemes which the government funds through Medicare. But apart from that, you also have the Max Fax scheme, which is Category 4. But that's basically for jaw surgeries. So if you technically include those, that'll be 3 schemes. But the actual dental scheme for adults, no.
There's no funding. Yeah.
No. That's through Medicare. However, the government, the Commonwealth, basically, so dentistry is a responsibility of the state. So the state government has to manage dentistry. It wasn't the case. Now, there's some history to this, and this sort of got me into policies and understanding what works with policies and where we are. And this might sound real theoretical. It was that Kingdom theory policy where he said that there are about 3 policies. If to determine a policy, there is a problem, there's a proposal, and there's politics. So, so inherently we have the problem. So we all know that dental diseases and oral diseases are a big public health problem. No denying that, and it's preventable as well, largely. So there is an option that you can prevent it. by investing. So there are proposals. So there's a lot of research that's been done that, if you act early, you can prevent conditions and ultimately the costs. But then the major problem here has been the politics and convincing the policymakers. All right. So what's happened is that we've evolved from the Commonwealth was heavily invested with the school dental program in between 1974 and 1981 in the Whitlam's government during that time. And then what happened was that was ended in the 1981 and 82 budget, if I'm going a bit in the history because it's important. And they said, look, dental is for the states. So some states continued with the school dental program, including Western Australia. So we still have a school dental service, which is run by the dental health services who run the school dental service, which is manned by therapists.
Just about in there, that's the caravans that go around to the schools, right?
Yes. Yeah. So you have that service as well. Yep. So that is run by therapists, and then there's an area dental officer that actually looks after that particular area. So that still is active in WA, but that's state funded. So it used to be Commonwealth funded before. So some states like Victoria and New South Wales have gone out of it and they've integrated that into their community programs, whereas states like SA and WA and Tassie still continue to implement it. So that was the major break where the states took up bulk of the responsibility. So coming back again to our current stage. So at this level, we have Commonwealth funding, which is through what we call, is that they call it an FFA. I don't really remember what the full form of an FFA is. So it's basically a set amount of funds which the Commonwealth gives the states. But then that's just a part of the state's dental budget, really. So it is activity-based again. So every state gets some money, and that money is for eligible people. So who are the eligible people? So the eligible people are those with a healthcare card or a pension card, etc. So I think that's how public dental service is, unfortunately. So most of us may be ineligible. So therefore, 85 to more than 85% of our people, we access dentistry privately, which is a problem, and public dental is a very small component of care. And unfortunately, quite a few of our people actually miss out of this because of this arrangement.
And people are turning away from private health insurance these days as well. So we can potentially foresee a urgent dental issue in Australia. I know anecdotally lots of people dropping it. Sorry, Junaid.
Historically, it's actually it's good that you bring that up. The government did try, so you shouldn't really blame the government for everything. So if you ask me, I might get some brickbats from my dental colleagues, but the government did try, and this was, I think, was it in 2007 to 12? I'm just trying to read that. It's called the Chronic Disease Dental Scheme. I don't know if you were aware of that. It's called the CDDS scheme, where people were actually given, or you can access about $4,250 over 2 calendar years. And what you required is a referral letter from your GP. So they had allocated about $350 million for it. And what happened was it blew out of proportion disproportionately, and it were billions of dollars of costs for the government, and they had to kind of abandon it in 2000, and I think it was in 2013 when they replaced it with the Medicare teen dental plan, which eventually kind of morphed into the CDBS, and look at the money which we get over 2 years. It used to be 4,200. Adults used to use it for a lot of denture services. Now it's gone to kids, and it's just 1,158. So basically, so the government tried. So to be honest, they tried. But I think the problem is, what we feel the problem is that there is a disconnect. There is a national oral health plan, which most of us work together, sat together, spent hours together with, developed it, but it doesn't get funded. So we don't have a chief dental officer at a Commonwealth level. We have at a federal level, but we don't have at a Commonwealth level to inform the government. So that's another problem, which there's a lot of discussion about in the dental public health fraternity, that we should have representation. So I think that's where the problem is. There is a commissions that have been put out by the government. Those commissions kind of inform the government for policy. Policies are made, and mostly policies are designed to underdeliver, or what tends to happen is you put out a policy like this, and it sort of balloons your budget, and then you just abandon everything, and then you just underfund. So that's what's happening.
Mm-hmm. Yeah, we've obviously seen that in a parallel with the NDIS. Governments are very risk averse to schemes that could sort of blow up out of control. Just to clarify, are you saying that there's a chief dentist in WA but not at the Commonwealth level?
No, so there's no one at the Commonwealth level. So we have a chief dental officer for WA.
Yeah,
we don't have anyone at the Commonwealth level.
Yeah, okay. So that just goes to show where we rank oral health in the order of priorities, doesn't it? Just like you were talking about before, because we have a chief mental health person, we have a chief medical officer, we have all these other aspects of health where we have, a chief surgeon. I'm not sure what the name is for the chief surgeon, but that's quite common in countries. But yeah, not one.
Director, is that Director General? I don't know.
Could be the Director General, or the Surgeon General or something.
Yeah, Surgeon General, yeah.
Yeah. But yeah, so that really just underscores where this sits in the order of priorities in health, and what makes conversations like this all that more important. If I'm understanding correctly, there was a budget announcement this week.
Oh, yes.
Yes. Tell us, Junaid. Enlighten us.
Okay. So we feel that there should have been more, because what appears to be the news, 300 million or 350 million is basically not adequate. Because what's happened there is that the FFAs, which I said, the amount of money that the Commonwealth funds the states, was surprisingly not permanent. Now they made it permanent, so it's a positive. So again, acknowledge the good things that have been done and the good decisions that have been taken. However, the amount that's been funded for adults is, like, when I looked into the budget, really, it's not 350 for adults. Like the regular, the amount of money which they give annually is about 170, something that was the same amount that was paid 8 years ago. So the money hasn't increased. The population has now increased dramatically. The needs have increased dramatically, but the funding hasn't kept up. Again, another problem with that is what I've realized being in dental public health, and again, the government does policies, that's a different thing, but are we measuring the right outcomes is we have to ask ourselves.
Yes.
So how the scheme works with the federal government is they value activity. So they give money with the aim that you would do n number of activities, and the activity measurement is based on treatment. So you're not focusing on prevention. And again, that's why we are introducing something called value-based care. So for instance, let me give you a simple analogy here. So you may have, say, burning mouth. You may have ulcers in your mouth. So what you need is basically a diagnostic appointment with the doctor, with the dentist. So what the dentist would do would review you. You might probably prescribe some medicines, and that medicines will actually relieve your ulcers. So how does this count from a funding model? It counts like you've done a diagnosis appointment. It's not a treatment. You're not giving that person a crown or a bridge or an implant. So that counts very low in the ladder, all right, in terms of the activity. But the value of that treatment is huge because the quality of life of the person is improved. Now the person can eat well. The ulcers now could have been worse. So you've relieved it, right? So that PREMS is what we're introducing now into our health system, which is patient-reported outcome measures. Patient-reported experience measures are important because the outcomes you're reporting as the dental fraternity is mostly surrogate outcomes. We are measuring how much treatment are we doing? What is the burden of disease? No, we shouldn't be measuring that. We should be measuring how much are we impacting quality of life. So the value-based indicators are extremely important, and the funding has to be tied to the value-based indicators rather than the procedures you do. Because what you're doing now is you're incentivizing treatment over prevention. Because Prevention,
Yes.
the preventative appointment is very cheap. I can apply fluoride that falls much under the bracket of funding. Then you're incentivizing the practitioner to do a lot more treatment and interventions, and so basically the funding model and how you measure outcomes itself is incorrect. So in a way, the current Commonwealth arrangement is also linked and tied to procedure codes, and they give a weight to the procedure codes, and those dental activities are largely treatment based. And I think that's where we need to move away from. So the value-based systems, what we can do, yes, we can hope the government will fund us more, but we need to provide them with more information.
One thing I've noticed from going to a couple of different dentists over the years is that they're running more and more like businesses these days, and there's been a big shift towards cosmetics, I've noticed, and not necessarily stuff in the mouth either, like, Botox and other things. Do you think that's a consequence of this funding kind of gap that we're seeing where there's an unmet need?
No, I think those are two different issues, I would say. So because the funding gap is public dental is very, very minimal. All right, in schemes of things. This is a completely different area and arena. This is more business related. This is where we as a dental fraternity need to reflect how far we're moving away from our social contract. So that's a completely different question. So it's as you said, it's become more like a business now. We want to make money, and at what cost? So basically, we had this really good discussion with colleagues in Sydney, and one of the things we were discussing is how TikTok, social media, the need to look good has actually influenced aesthetic dentistry and the requirements for veneers, all those Botoxes and all we're talking about. We're talking about functional health. So when we studied dentistry, it was form, function, aesthetics. So aesthetics was third, and it was mostly, are your teeth proper? Are they healthy? And are they functioning well? So that was what is important. Then comes how it looks and the vision. Now it's become the opposite, so that is different from the funding model. And anyways, the funding model will not fund aesthetic treatment from a public perspective. Privately, yes, I think it's mostly business. The business model is what I would put it.
It's a grey zone, isn't it? Because it does tie into your social acceptability too. Like, you look at the Hollywood movie stars, the first thing they do is go and get their teeth done. And
because I've had a few patients who have, if you ask me, they have decent teeth, but then they would ask whether they can get some bleaching done for their teeth. And it would be like, I mean, for me, from my eyes, they look okay, but for them, they want white teeth. So that notion that your teeth are healthy if they are white is something which is more propagated through social media and all that stuff.
And it leads to absurd outcomes for some people where you're just like that.
I know what you're talking about, Craig.
The other thing is, I know people who put the treatment on to whiten their teeth with the mouth guard, the peroxide or whatever.
Yeah.
And then they've got really sensitive teeth for days afterwards because it's,
it's a chemical anyway.
Yeah.
So the distinction of having clean teeth as opposed to white teeth is important. Having less deposits around the tooth is more important than having white teeth. Your gums have to be healthier, your teeth have to function well, and all that stuff is more important, really.
So moving away from your clinical hat and putting your researcher hat on, what do you think are the research priorities that we need to be looking at both here in Australia and also around the world?
Yes. So with dental public health, so when I assumed this role, there's a lot been done from an observational perspective. So observational work is huge. So we've reported a lot of inequities. We've looked at it from the intersectionalities of things, that rural remote issues, the challenges we have with our Indigenous and Aboriginal populations. And it's huge. It's mostly a disease of inequity, basically, much like how rheumatic heart disease is. So people who mostly need services don't have services. So we have the inverse care law. So most of the dental practices are in the metro as opposed to rural. So all this have been reported. So, but what's not been reported enough is what are we doing about it? So we're moving away now from at least slowly, from what is observational research to more implementation research, just test models. So this is a very interesting time that I bring this thing up, which I've been involved with from my time here at the Oral Health Centre. And the project is about to kick off, and I hope it works well. We call it the Buja Smiles Project. So this initiative was thanks to Judy, of course, the person. You don't know how this relationship developed. So and Ingrid knows this well, and probably the people who are listening to this podcast won't. So I briefly worked with Judy with the space of rheumatic heart disease, and that was my real experience of Aboriginal health for me, really. And now once I got this job, Judy sort of introduced me to Melanie Robinson from the Aboriginal Head at Cars, and we had this conversation, and we just kicked it off. And the conversation was around why Aboriginal kids actually use Coke in their milk bottles. And that sort of hurt Mel. It just started with that small discussion. And I said, look, I'm getting into this position. We need to work closely together. And she agreed. And the other thing which we shared was also a common heritage, because Mel's mum is an Indian.
Really?
Heritage. So that sort of broke the ice as well to some level. And we had this lovely conversation that day. And then that conversation, one thing led to the other. And we've got the Aboriginal artwork at the school, that thing. And then eventually Mel introduced me to this lovely lady by the name Riley McAllister. She's not Aboriginal, but she's a beautiful lady who's been working so much for the community at Midvale Hub in the Shire of Mundaring. That's what they are. They are a community hub. And I sort of liaised with her. Meetings later, then we built that network, that connection, and now students go there for placements, for health educational placements at 9 schools and daycares. And now we've donated a dental chair, and the screenings are going to start. And then we are going to refer them to the Oral Health Centre for treatment. So basically what we're doing now is we're going to research that model. And we're going to see, is this working? Is that hub and spoke approach working? Can organizations like the Oral Health Centre, which are tertiary organizations, can we connect with the community by having, kind of small little screening settings, or even small little outposts there, and in the community, and then use the community and the peer support workers to help us engage with the community and improve the trust. So that's what is the Buja Smiles project. And I think we are trying now from a very small level to test those, and that's what is implementation research, basically. And that's one of the reasons why I thought I need to upskill in that area, and that's why I enrolled into that program from the University of Sydney, which they selected me. So I'm glad that I'm learning a lot in that area.
So yeah, it's interesting, because I've seen similar initiatives, not in the context of oral health, but in sort of social support. And one example that comes to mind is the community legal centres embedded legal advisors in other centres, where people might go for assistance, like homeless shelters and other places, FDV places, etc., because they know that people don't have one need, they've got multiple needs. And I'm wondering if it's ever been thought that maybe someone with a dental sort of health background might be in a community centre to sort of offer advice.
We have that. We have that.
In
WA we do. So for family and domestic violence, for individuals who experience that, we have something called Healing Smiles. And that's a lovely voluntary organization, which I have my colleague is Dr. Lida, and she works with me. And we have this lovely conversation of integrating programs together, because she's been championing this. And it's a group of volunteer dentists who kind of spare their time to pro bono practice, basically, from their private practice, see patients, offer treatment for free. It's funded by the community. So I think those models are alive, and now we're trying to test them as well. So my fellow colleague who works with me at the UWA Dental School, she's worked a lot in this space, and she's from Sweden, and she's now engaging with Healing Smiles along with me and other people, and we're trying to sort of establish that, is this a good model? But then pro bono, but how do we upskill it? We have pro bono dental services at St. Pat's as well. We have a lovely dentist there by the name Dr. Ali Maki. So she sort of is in touch with us because we send our students there as well. So it's a good connection. I think what we have to do is the future is that our training has to move away again. Again, it's also workforce training, which is important. Currently, our training is very biomedical, very hierarchical.
Yes.
So that is important as well, because as dentists, when we graduate outside, we don't think about the person, we think about the mouth. And I think there is, again, a social obligation which we have. And as young dental students, it becomes hard for them to understand that. Again, they're affected by multiple reasons. Some of them have really high loans which they need to pay off. So again, the lure of private practice is huge, and the public practice, the remunerations have to increase as well. So again, if you want doctors to work rural, if you want doctors to work remote, you need to pay them in par with what you pay, not in par with private, but at least higher than what we get currently, because that again dissuades young graduates from joining. So there's a lot. So there's this problem is not just very few dentists. It's about maldistribution of dentists. And again, skill mix is important as well, because we need to understand that oral health is not just a dentist's responsibility. We have therapists, we have our dental assistants who help us. Because when I went to Geraldton for the rural placements, we had this discussion. The thing which came up was there are dentists, but there are no dental assistants. So because of that, they're not able to function. So the importance of having that skill mix, how well can we incorporate and upskill our Aboriginal health practitioners for fluoride applications for that matter. So it's a topic which is very complex. And again, I don't know if I answered your question.
No, you did. And I think it reflects the sort of health economic issues that we see across health services, including primary care. There's a real imbalance and inequity about where GPs are concentrated versus the geographical need, and the rural remote areas often get overlooked and underserved. So it's not a new issue. It's just one that needs to be addressed. Yeah.
It's very complex. And again, that's the other thing. When we have, like colleagues, we have this discussion, we say, look, we are asking for governments for all this extra funding, but we need to show them what we can do with our funding for them so that they know that, a lot can be done, and so they can fund a lot more. So that's why I think that the dimension or the direction where we're moving into in terms of research is implementation research. We want to show them, look, we can do with what money we have and you give. And can this be scaled up? Can this be up, just raised up to the next level? So I think that's where the future of dental public health research is headed.
It sounds, like an exciting time as much as there's challenges. And also there's an opportunity to sort of demonstrate savings to other parts of the health system if you do oral health prevention well,
Because that's the, sorry.
Go ahead.
Sorry, Craig, I'm just stopping you. Okay, so that sort of saves you on your preventable hospitalizations and the cost which you spend.
So we're sort of coming towards the end of our chat, which has been a fantastic conversation, Junaid. Just wondering if there's people out there listening who are thinking about a career in oral public health, what advice would you give them?
Yeah, I mean, there are a lot of differences in how we use the name of the specialty. So it's a registrable specialty in APRA. It's called public health dentistry. So that's what we call it. Dental public health is the science behind public health dentistry. So it's used interchangeably. So it depends on whether you want to become a specialist or you're looking at becoming, or rather advancing your knowledge in dental public health as a science. So for those who are interested to become specialists in APRA, you have to be a general dentist, and then you need to do accredited programs in public health dentistry. But currently in Australia, there's just one offered by the University of Sydney at the moment. So if you're interested, that's your place where you have to approach and hope that you get it. And it's a bit hard to get into it because they see that whether you have your public health experience, after that, whether you worked in public dental and what skills you have that you can upskill. So that's the aspect of becoming a specialist. But if you're not looking and that's not what you want to do as becoming kind of a specialist and do that stuff, but you're more keen on the science aspects, you don't really have to be a dentist, to be honest. You could be a public health person, but you can kind of streamline yourself into dental and understand dental health and oral health better. Probably think about a PhD, become an oral epidemiologist, research this area. You don't need dental skills for this, but dental skills would be better because it helps you understand, as I said, that clinical and connect with public health is always there, and that's the advantage, but it's not a limitation. So I think if you're looking for a career and to become a dental public health professional, you don't have to be a dentist. You can be anyone. You have to have strong public health skills, and your research should be mostly dental related.
Great advice.
Yes, we need all of these specialties, don't we, to advance the field here in Australia.
Yeah, great. Well, Junaid, it's been an excellent conversation. Really interesting to hear your experience and expertise, and I'm heartened to hear that there are people like yourself working with the community, because it's such an important area. Thanks very much for making the time to have the conversation today. It's been great.
Thank you so much for having me, both of you.
Oh, thank you, Junaid. It's been great.
The Meaning of Health is produced at the University of Western Australia with the support of the School of Population and Global Health, the Digital Development and Enhancement team, and the Infrastructure and Platforms team. The podcast is produced and hosted by Craig Cumming, Courtney Weber, Leah Roberts, Ingrid Stacey, and Dorinda Tahar. Music, mixing and post-production is done by Craig Cumming. You can find more information about us at our website, meaningofhealth.com.au. If you would like to get in touch with us, you can email us at meaningofhealth@outlook.com and contact us on Instagram or Blue Sky at Health Means What, or find us on Facebook or LinkedIn by searching for The Meaning of Health.